Hello, my name is Ann Borders. I'm a maternal fetal medicine physician and the executive director of the Illinois Perinatal Quality Collaborative. We have been leading an initiative in Illinois called the Mothers and Newborns Affected by Opioids Initiative, with the goal of providing optimal care for women with opioid use disorder and their newborns. Today, we're going to be discussing the critical role of the OB clinical team, and in particular, the nurse, in caring for women with opioid use disorder. As an overview of what we're going to be discussing today, we will review the background of the opioid epidemic and its implications for perinatal care, specifically that opioid use disorder is now one of the leading causes of maternal death. We will discuss key treatments for patients with OUD and how we think about opioid use disorder as a chronic, life-threatening medical condition with life-saving treatment available. We will review screening and linking to care for women with OUD, the OUD protocol implementation, initiation of a substance use disorder, opioid use disorder clinical algorithm, and a clinical care checklist, how to provide patient education regarding OUD and NAS, and the need for staff education to reduce stigma. Finally, review key strategies and clinical care team roles. The opioid epidemic has ravaged the US. When we look at the number of deaths that has significantly increased from 1999 to 2018, in the most recent year, over 46,000 Americans died from overdose related to opioids. Pregnant women have not been left out of this crisis. Opioid overdose is now the leading cause of maternal death in Illinois. Pregnancy-associated deaths related to opioid poisoning have increased by tenfold. In 2016, there were 10 maternal deaths related to opioids, and in 2017, 20 maternal deaths related to opioids. In comparison, in that same year, there were 6 maternal deaths from hemorrhage and 6 from hypertension. Opioid overdose is a leading cause of maternal death and something that every obstetric clinical team must understand is an urgent obstetric issue. It is important to understand that opioid use disorder can happen to anyone. No one chooses to have opioid use disorder. Over 20 million Americans are struggling with a substance use disorder currently. 2 million of those Americans have a substance use disorder involving a prescription pain reliever, and about 500,000 involve heroin. This is a crisis in the healthcare system in our country that we as healthcare providers must grapple with. I think it's important as we're understanding why we must do this work, why we must do the hard work of trying to figure out how to provide optimal care for every woman with opioid use disorder. We must remember the women who've lost their lives to this disease. When we see these pictures of Madeline and Anaya and their children, it reminds us that this is a fight that we must fight for every mom. One additional mom who loses her life to overdose is one too many. And it's up to all of us to provide optimal care for these moms during this window of pregnancy and the postpartum period, when we have an opportunity to help women get onto medication-assisted treatment and on the road to recovery to reduce the risk of maternal death. Remember that OUD is a life-threatening medical condition, and that linking women to opioid use disorder to treatment and services reduces overdose deaths for moms, improves pregnancy outcomes, and increases the number of women who can parent their baby. It's so important to remember why we're doing this work. I think it's really important that we understand that treatment works. Remember, opioid use disorder is a life-threatening, chronic, treatable brain disease, and it can be managed successfully by combining medications with comprehensive care and recovery support. Treatment enables those with OUD to regain control of their health and their lives. Opioids change brain chemistry. When a woman starts using opioids, she's using it for pain control or for euphoria. But very quickly, the brain chemistry changes. And this is when it becomes a brain disease. Medication-assisted treatment, or MAT, is the standard of care for opioid use disorder in pregnancy. It is endorsed by the American College of OBGYNs as the optimal treatment for OUD during pregnancy. All OB providers should understand that methadone and buprenorphine are safe and effective treatment for opioid use disorder and pregnancy. The goals of treatment with MAT are to alleviate signs and symptoms of physical withdrawal, diminish and alleviate drug cravings, and most importantly, normalize and stabilize perturbed brain neurochemistry so that women can move into recovery. In order to understand opiate use disorder as a chronic brain disease, it's important to understand the pathway to addiction. When women first use opioids, they can move from feeling normal to having euphoria. But that feeling of euphoria to normal only lasts a short amount of time and really only represents acute use. When someone uses opioids over time, they begin to develop withdrawal symptoms. So that as they take opioids, it makes them feel normal. And when they're not using, they move into withdrawal. This is that altered brain chemistry that leads to addiction. And this is why treatment for substance use disorder works. When women take medication-assisted treatment, instead of moving from withdrawal to normal and back to withdrawal, or even from normal to euphoria, they just feel normal. And this is so important as a tool to stabilize brain chemistry and move women into recovery. MAT has many benefits for both moms and their fetus. Very importantly, in addition to moving women into recovery, it is so important that we understand that it has significant reduction in risk of overdose deaths. It decreases risk of HIV, hepatitis B, and hepatitis C, increases engagement in prenatal care and recovery treatment, and other services that women may benefit from during pregnancy and the postpartum period. Being on MAT increases the number of women who can parent their babies. And for the fetus, we see many benefits, including reduction in fluctuations in maternal opioid levels, which can reduce fetal stress, which is thought to reduce risk of intrauterine fetal demise, intrauterine growth restriction, and MAT has also been associated with reductions in preterm delivery. For women who are pregnant and postpartum, medication-assisted treatment saves lives. This study from Massachusetts shows in the gray overdose events when women are not on medication-assisted treatment, and in orange overdose events for women who are on MAT. And you can see about a 50% reduction in death for women on medication-assisted treatment. And importantly, you see that overdose deaths increase in the postpartum period. This is a time of great risk for women, and why it is so important that we take the opportunity of pregnancy as a window to identify women with opioid use disorder and get them started on medication-assisted treatment and into recovery treatment services and programs, and then continue to follow them closely through that postpartum period and beyond. Why is postpartum so risky? Why do more women have overdose deaths during the postpartum period? We know that there's an increased risk of relapse in the postpartum period, and that women may have reduced tolerance if they've reduced the dose of opioids they've been taking during the pregnancy, or even abstained, and then relapse in the postpartum period. Reduced tolerance increases the overdose risk. A woman may go back to using the same dose she was using before, but as her tolerance is reduced during pregnancy, she is now at significantly increased risk of overdose. We know that women receive more support and more resources during pregnancy, and that there's a reduction in support services and resources overall in the postpartum period. This is such a critical time for mom, which is why we must increase support and resources during this time period. We also know that there's shame and stigma involved with neonatal withdrawal. This is why it's so essential that as clinical care providers, we understand that shame and stigma costs lives, reduces the care we can provide, and worsens outcomes. High rates of co-occurring depression and anxiety and social issues occur and are exacerbated after delivery for many women. Our goal is having moms in treatment and on medication-assisted treatment with recovery services and a Narcan prescription and close postpartum follow-up in order to reduce the risk in the postpartum period. Safe discharge planning for mom and baby saves lives. Nurses play an incredibly important role in making sure that women receive the education and services and resources they need before delivery discharge. It's so important that the clinical care team consider what is needed for these moms before they're discharged from the hospital in order to make sure that women receive the optimal care during the delivery mission to reduce the risk of maternal death in that postpartum period. Let's talk about some key clinical strategies to provide optimal obstetric care for women with OUD to promote recovery and reduce risk of maternal death. The Mothers and Newborns Affected by Opioids Initiative kicked off in May of 2018 with over 100 Illinois hospitals. Our goal was to increase the number of women receiving medication-assisted treatment and connected to recovery treatment services prenatally or by delivery discharge by over 70%. We also had a set of aims that are really important that our hospital teams are working on across the state in order to provide optimal care for women with OUD. Our goal is to have over 80% of patients screened with a universal validated opioid use disorder screening, both prenatally and on arrival to labor and delivery. To have over 70% of patients on medication-assisted treatment during pregnancy or before delivery discharge. To have over 70% of women with OUD linked to behavioral health treatment and recovery treatment services. Over 70% of patients have an OUD clinical care checklist in their chart and be completed by the clinical team. Most importantly in that checklist, making sure that Narcan or naloxone has been provided for that patient and that a hepatitis C screen has been sent. And importantly, our goal is to have over 80% of patients receive documentation of patient education on OUD and NAS. This can be reviewing and counseling patients using patient resource materials from ILPQC, and importantly, a neonatal or pediatric consult to discuss NAS. In order to be successful to achieve these aims, it became very clear early on that most importantly, we needed the OB providers and nursing clinical team to understand some very key issues about opioid use disorder in order to provide optimal care. First, that opioid use disorder is an urgent obstetric issue. Understanding that it's a leading cause of maternal death and that pregnancy is an essential window in order to assess women's risk for OUD, assess their readiness to start treatment, and link them to MAT and recovery treatment services, and particularly since the postpartum period is so risky. Second, we need clinical team members to understand that opioid use disorder is a life-threatening chronic disease with life-saving treatment available. Reducing stigma improves outcomes. Third, that there are key steps that OB providers and nurses need to take prenatally and on L&D to care for women with opioid use disorder. Linking moms to MAT and recovery services reduces overdose deaths for moms, improves pregnancy outcomes, and increases the number of women who can parent their baby. We often hear, why link moms to treatment? Why do this work when there's a risk of relapse? It is so important that we understand that it takes one provider, one nurse to provide empathy and assess readiness for treatment and help women on her road to recovery to reduce that risk of overdose death, to improve outcomes for mom and baby, and increase the number of women who can parent their child. The MNO OB Protocol lists the key steps that the OB clinical team needs to take for every patient with OUD. First, screen with a universal screening tool and document a positive result. Next, an OB provider needs to go in and assess the patient's opioid use disorder. This is often called SBIRT, screening, brief intervention, referral to treatment. But what it really means is going in and talking to the patient. We must provide brief counseling regarding the benefits of treatment and assess readiness for medication-assisted treatment and recovery services. Next, we need to activate care coordination and navigation to link women to MAT and behavioral health counseling and recovery programs and provide close follow-up with warm handoffs. Next, we must insert and complete the OUD clinical care checklist, either an electronic medical record, if it's available, oftentimes through a dot phrase, Or if you're using a paper record, scan it in so that it's available in the patient's chart. Finally, it is essential we provide all patients with patient education regarding OUD and NAS. This can be done regarding counseling and patient education handouts from ILPQC, and also, of course, through a neonatology or pediatric consult. Remember, activating the OUD protocol for every screen-positive mom reduces maternal deaths, improves pregnancy outcomes, and increases the number of women who can parent their baby. It is essential that OB providers and the clinical care team understand that pregnancy is an important opportunity that we can provide optimal care for all women with OUD. A reminder of the steps: screen every pregnant patient for OUD with a validated screening tool, assess readiness for MAT, start MAT and link to recovery treatment programs, provide naloxone or Narcan counseling and a prescription, and screen for hepatitis C. Provide warm handoffs for MAT recovery services and close obstetric follow-up. And finally, provide patient education on OUD, NAS, and reduce stigma, promote empathy across your clinical team. Let's talk about a few of these steps. First, universal screening for substance use disorder, opiate use disorder with a validated screening tool. We really need to move to using a universal validated screening tool for all patients, both during prenatal care and on admission to labor and delivery. This is recommended by ACOG, SMFM, and ASAM. We used to use screening that was simply a one line, do you use drugs, smoking, alcohol? That is no longer acceptable. It is so important to know that universal screening with a validated screening tool is the new standard of care. It is important to screen all pregnant women on entry to prenatal care and then on admission to L&D and document that that screening has occurred. This allows for the earliest possible intervention and referral to treatment. The goal of screening is to identify pregnant and postpartum women with a life-threatening illness in order to start treatment early in pregnancy or before delivery discharge. Here are some examples of validated screening tools that you can use at your clinical site that are available on www.ilpqc.org if you want more information. When a woman screens positive, we talk about SBIRT. SBIRT is simply the key steps for an OB provider to respond to screen positives for substance use disorder or opiate use disorder. It stands for screening, brief intervention, and referral to treatment. What it really means is that a member of the clinical team needs to walk into the patient's room and talk about their positive screen with the patient and assess readiness for treatment. It has been shown that a brief, even less than 5-minute discussion providing feedback and advice from a provider can be very powerful in helping patients to change behavior. It is important to assess the OUD diagnosis, briefly discuss risks of overdose and neonatal abstinence syndrome, and the patient's goals for her pregnancy. And finally, most important, assess readiness to start MAT and link to recovery treatment services. We need to provide a warm handoff to start MAT and recovery services, and then close follow-up for each of these patients. Many providers want to utilize the SBIRT pocket card that is available through ILPQC that has some key counseling pearls and then a readiness ruler. Next, I'm going to use an example to walk us through what an SBIRT might look like. This is for a patient who's using marijuana. Again, SBIRT is for any patient with substance use disorder, not necessarily opioids. But of course, every patient who screens positive for opiate use disorder, we need a provider to walk in the room and talk to the patient. So let's walk through this. Thank you for answering these questions. I noted that you're occasionally smoking marijuana. Is it okay if we talk about marijuana use and pregnancy? Sure. People use drugs for many reasons. Can you tell me what you like most about using marijuana and what you like less? I do like the way it makes me feel, and it helped me a lot with my nausea. I've heard it's safe and doesn't hurt the baby, but I guess I'm not sure. That is a very common perception. I have information on marijuana use and pregnancy, and I'd like to share it with you. Provide counseling and share educational handouts. What are your thoughts on the information I just shared? On a scale of 1 to 10, how ready are you to make any changes in your use of marijuana? This is a readiness ruler that can be used by nurses and providers in order to assess a patient's readiness for change. 1 being not ready and 10 very ready. You don't need the actual ruler. I use this all the time and just ask a patient on a scale of 1 to 10, with 1 being not ready and 10 being very ready. Where do you stand on making a change? This patient chooses 6. Okay, a 6, that's great. Why did you choose a 6 and not a lower number, like a 1 or a 2? Well, like you said, if a joint might hurt my baby's development, I don't want to keep using it. But what about my nausea? We have other things that can help you with your nausea that are not harmful to your baby. I have other resources and people that patients often find helpful. Would you like to meet with them? Thanks for talking with me. Can we schedule a date to check in again soon? Sure. So that is an example of a quick SBIRT. And again, all it means is walking in the room, talking to the patient about their results of their opioid use disorder screen. It is so important that we walk in the room, talk to our patients, and assess readiness for treatment. We've also been talking a lot about a warm handoff. What does that exactly mean? A warm handoff includes helping in the process of getting a patient linked to treatment and resources. It's making sure the patient has an appointment and a follow-up is set up. If the patient declines MAT or recovery services, then it's important to schedule a short interval follow-up with the OB provider. It is not just providing a phone number to the patient and having the patient call. It is not just giving a list of resources to the patient. And it's not just a phone call to a social work with no additional follow-up. Next, I'd like to talk about the ODD SBIRT clinical algorithm. This is one of the most important components that we are going to talk about today. If we had to think about one slide in this entire presentation that's important for the clinical team to understand, I think it's encapsulated here. For both the provider and the nurse, it's so important that we understand the key steps that are needed to take optimal care of these patients. I think for a long time, we thought when a patient screened positive for OUD, this was someone else's issue, addiction medicine or social work. We now know that it is absolutely the role of the OB clinical team to provide optimal care and help reduce the risk of maternal death. These are the key steps that the clinical team needs to take. And this is important for both the OB provider and the OB nurse to understand in order to provide this optimal care. For patients who screen positive, it may be that they just have risk factors and just need someone to talk about risk reduction. But if they screen positive for opioid use disorder, we need to move to the left-hand side of the slide. And what's so essential is that a member of the clinical team, particularly the OB provider, needs to walk in and talk to the patient about their positive result. When a patient screens positive on a validated screen tool for OUD, it's so essential that a member of the clinical team go in, talk about and assess the woman's diagnosis of opioid use disorder, counsel on risks of both overdose and neonatal absence syndrome, and assess readiness for treatment. Assessing the readiness for treatment and linkage to recovery treatment services is the most important thing that can come out of that conversation. We need to align ourselves with our patient, talk about their goals for their pregnancy, and oftentimes goals of treatment and recovery services align themselves exactly with a woman's own goals for her pregnancy. Going down below that purple box on the left-hand side, we see how to link a mom to MAT. On the far left, if a mom's in withdrawal or ready to start MAT immediately, a really good option is admit to the hospital for a fast-track MAT start. There are a lot of resources there to help stabilize a mom on MAT and then discharge them into a recovery treatment program. If it's unclear if MAT is indicated or if they're not ready to start MAT, or if we know that there's outpatient MAT available and it's a good choice for that patient, then we initiate outpatient stabilization with social work support with a warm handoff to behavioral health and a recovery treatment program. Recovery treatment programs can look differently and different patients may need different levels of support. This may be an inpatient treatment program, it may be an intensive outpatient treatment program, or a behavioral health treatment support, or a peer support program. On the far right side of the slide is where we start the OUD clinical care checklist. It is so essential that the nursing team remind the OB provider and the overall clinical team that the checklist must be completed for every patient with OUD. This is so essential because some of the really important risk reduction strategies are here in the checklist. I want to highlight Narcan counseling, making sure that every patient gets counseled on this risk reduction strategy and gets a prescription for Narcan. They should get a hepatitis C screen, serial tox screens with consent, and then a series of consults that may help our patient with optimal care. It is really important that we include contraception counseling and other patient education on this list. In the middle, we have some of the documentation that is necessary for moms with opioid use disorder. How to document OUD in the problem list, and then how to bill for expert. This is more to remind the overall clinical team, and particularly the provider, on these key steps. At the very bottom are some key numbers that can be utilized by the clinical team in order to provide optimal care. Both a hotline that has local treatment options for recovery treatment services and MAT, if you're not sure where to send your patient or how to link them to care. At the very bottom is a hotline that's operating Monday through Friday, 9 to 5, that provides a free addiction medicine consult for OB providers caring for pregnant and postpartum women with OUD, with questions about OUD or MAT or starting MAT. So let's talk about a system that can be used to activate this OUD protocol for every patient. There are resources available through the ILPQC MNO initiative to help all obstetric clinical teams provide optimal care for all patients with OUD. We realize that for many clinical teams, they may not see many patients with OUD. Some hospitals have 1, 2, 3 patients with OUD a year. This means that an OB provider may see this situation and this condition not frequently. But for every life-threatening medical condition we see, we need to understand how to respond. And so putting systems in place that make sure that we provide optimal care for every mom with OUD, regardless of how often we see it, is really essential. We want to make sure that every patient with OUD receives optimal care. This is so important given the high risk of maternal death from OUD. We need these systems to make sure that optimal OUD care is provided for every patient and every time. The following systems have been used by hospitals and prenatal care sites around Illinois to improve the care they're providing for patients with OUD. MNO folders are used by many hospitals and prenatal care sites around Illinois as a way to contain the resources for providers, nurses, and patients in one location for when a patient arrives and is identified with opioid use disorder. We'll be reviewing the steps for using the MNO folder and what's contained in the MNO folder in a minute during this eModule. Many hospitals have moved to using prenatal care team conferences and labor and delivery care team huddles in order to bring together a multidisciplinary group of providers in order to make sure patients are receiving that optimal care. For prenatal care team conferences, this is an important opportunity for obstetrics and neonatology, nursing, and social work to talk about a patient who's been identified with opioid use disorder during the prenatal setting and make sure that they receive the needed care, including linkage to MAT and recovery treatment services, Narcan counseling, neonatology consult, and other key clinical steps. Labor and delivery care team huddles have been implemented by many hospitals around Illinois to be used when a patient with OUD is identified on labor and delivery. These are often called by the primary nurse or the charge nurse. The huddle would include the obstetrician or MFM, nursing, neonatology, social work, anesthesia, and addiction medicine or psychiatry if appropriate. It is a great opportunity to be able to utilize the MNO folder and make sure that the checklist and care plan have being utilized and that optimal care has been provided. In order to remember the key steps for prescribing Narcan or for writing a hepatitis C screen or the consults that are being utilized, many hospitals have moved to using OUD order sets. An order set can help providers remember how to prescribe Narcan, which consults are needed, and simplify the process of making sure the patient receives optimal care when they arrive for the delivery admission. As part of the MNO initiative, most hospitals in Illinois have worked to create MNO folders. These are folders of resources with both patient education materials and clinical team resources that can be stored on labor and delivery and also in prenatal care locations in order to be available for every patient who comes through with OUD, in order to provide the right resources for the patient and the right resources for the clinical care team to provide optimal care. Let's go through this briefly, but make sure that you have MNO folders available both on your labor and delivery and in your clinical care sites, and that when you do identify a patient with OUD, that you ask for an MNO folder. It's going to make everything much easier to provide optimal care. On the left-hand side, patient education materials. These are materials that are going to help a mom better understand the benefits of medication-assisted treatment and also really understand neonatal abstinence syndrome and their role in providing optimal care for opioid-exposed newborns. There's also materials on contraception counseling and other patient education materials we want the patient to receive and have the nurse or provider go over with the patient. On the right are clinical team resources, the clinical algorithm that we reviewed, the clinical care checklist that we'll talk about next, and then really important, some Narcan clinical care guides that are so important that we'll also review. The first is a quick start guide that helps providers to provide this information to their patients so that they understand how to use Narcan at home. And a Save a Life guide, which is really for the OB provider to understand how to counsel and how to prescribe Narcan naloxone, given not everyone does this every day. And finally, there's a nursing workflow. This nursing workflow and OUD protocol really help the nurses on the clinical team to better understand what their role is to provide optimal care for every patient with OUD. This is an example from a hospital here in Illinois that shared a picture of one of their folders open with materials coming out of it. Remember, it's really important to keep these folders both on labor and delivery and in prenatal sites. And for every patient that you identify with OUD, that someone remembers to go get the folder and utilize it so that you have the resources you need to provide optimal care. The OUD clinical care checklist is a really important component of that MNO folder. In here, you have the key elements of care, a date, and comments. It's so important to include this in the patient's chart so that the care team that cares for the patient that day can start the checklist, and the next group of folks who see this patient at the next prenatal visit or during that delivery admission understand what has happened, what's been completed, and what is still left to be completed in order to provide optimal care for this patient. Some of the key checklist items include assessing for readiness for MAT, linking to recovery treatment programs, Narcan counseling and prescription, contraception counseling and plan, hepatitis C screening. Again, things that we must do for every patient with OUD in order to provide optimal care. The nursing workflow is a really important resource in the MNO folder, and I want to take some time to go over it. It is so important, the nurse's role in making sure that every patient with OUD receives optimal care. On the left-hand side, we have the labor and delivery nursing task list with a section for comments and notes. And on the right is the postpartum or delivery discharge nurse. The nursing workflow allows nurses to figure out what has been done and what needs to be done, and then pass off information between nurses to make sure that the key elements of care are completed for every patient before delivery discharge. So let's start with the workflow resource and focus on the labor and delivery nurse. So the labor and delivery nurse is a really important role of going and getting the MNO folder. So making sure that when they have any patient with OUD in their problem list or who screens positive for the OUD screening tool on admission, that someone goes to get the MNO folder. The nurse on labor and delivery has a really important role of working with the obstetrical clinical team to make sure that all key elements in the workflow are completed prior to delivery and are transferred to postpartum. Their job is to assist in activation of the OUD protocol and the use of the OUD clinical care algorithm by the care team. So going to get the clinical care algorithm out of the MNO folder, going to the OB provider and saying, here is the algorithm that we need to follow with this patient. This is what needs to be completed. Make sure that the patient receives the patient education materials. Not every patient in labor and delivery is going to have the time and ability to review these materials. And that's where the communication with the postpartum nurse is so important. If a patient comes in complete and there isn't time to discuss this on labor and delivery, we really need to pass this off to the postpartum nurse. It is very important to assist with obtaining a neonatology consult for every patient with OUD so that moms can understand their role in caring for opioid-exposed newborns and what exactly is going to happen in assessing their baby for NAS. We need to assure appropriate labs are drawn, including a hepatitis C. We need to verify that the OB provider has assessed readiness for MAT treatment and a plan for treatment is documented. Confirm the OB provider has access to the MNO folder materials for Narcan counseling and prescription. We all need to make sure that we do a better job of providing every patient with OUD access to Narcan naloxone prescription. So whether this happens during the labor and delivery time or during the postpartum time, the important thing that there's communication between nurses and we know whether this has occurred before the patient is discharged. Complete the labor and delivery admission nurse section of the MNO nursing workflow and then provide a handoff to the postpartum nurse to review the completed tasks. So let's switch to the postpartum nurse. We want to make sure that you review the completed tasks with the labor and delivery RN using the MNO nursing workflow. And then again, work with the obstetrical clinical team to make sure that key elements are completed prior to discharge. Assist in engaging moms and families in newborn care. This is such an important role of the postpartum nurse, providing empathy and support and helping moms engage in newborn care. Women are most successful with breastfeeding, rooming in, and eat, sleep, console when they have a supportive nurse who's providing that empathetic care. Confirm the patient is receiving MAT treatment and or has a plan for treatment follow-up postpartum and that it's documented. We shouldn't allow patients to be discharged from the hospital unless they've been assessed for readiness to start MAT and a plan is put in place. We must confirm the patient has been linked to behavioral health or recovery treatment program and that appointment is made before discharge with close OB follow-up. We should confirm that every patient has received Narcan counseling and prescription and that it's provided prior to discharge. If you have a med-to-bed program at your hospital, this is a really important way of making sure that the patient has the Narcan in their purse before they're discharged from the hospital. Remember, when you get a Narcan prescription, you usually get 2 packs. We encourage 1 to go to the patient and 1 to be shared with the family. We want to verify that hepatitis C results and a plan is established for all positive screens. And then finally, we need to really be thinking about how we can promote understanding of reduced stigma and increased empathy across the clinical team, and that this is really going to improve outcomes and improve the chance that this mom is going to be successful on her road to recovery. Remind the clinical team that OUD is the leading cause of maternal death in Illinois to understand why these clinical steps matter. Providing patient education on OUD and NAS. This is really critical, important part of the nurse's role on the clinical team. These patient education materials are available in every MNO folder. So if you have MNO folders on your labor and delivery or in your prenatal clinical site, it's really important to get these materials out of the folder and review them with the patient. These materials can go over the benefits of medication-assisted treatment for patients, prescription pain medicine, opioids in pregnancy, what all pregnant women need to know, and then some really good handouts on neonatal abstinence syndrome and what moms need to know to care for their baby. The one that I like so much, it says neonatal abstinence syndrome, what you need to know. Be with your baby. You are the treatment. It's so important that this information is covered. Treatment for OUD during and after pregnancy, OUD and NAS, maternal participation in newborn care, including rooming in, eat, sleep, console, and breastfeeding for opioid-exposed newborns. It's so important that we all understand that pregnant women have the greatest engagement for OUD treatment and recovery. It's such a window to help women on the road to recovery and reduce risk of maternal death, particularly in the postpartum period. Remember that it's important that women receive these educational materials and someone reviews them with them, and also that they have a neonatal consult. It is very empowering for moms to understand their role in the care of their newborn. The earlier they understand it in pregnancy, the better. So doing this during prenatal care can be really empowering for moms. And again, thinking about it when a mom comes in for delivery. Many hospitals have moved to special visits where moms come in and have a consult and get a hospital tour and really think through how they're going to participate in their newborn's care. And also being able to know a nurse and someone who's going to be their advocate even before they come to the hospital can be so empowering. We all need to figure out how to do a better job of making sure that every mom with opioid use disorder or any mom who takes opioids regularly has been counseled for Narcan naloxone and has a prescription. This must be documented in all charts for every patient with OUD or who takes opioids regularly. It is an essential risk reduction strategy that we must take advantage of it. I think for too long in OB, we have thought that someone else will manage this, that there will be an addiction medicine doctor or an MAT provider or someone else who will talk to the patient about Narcan naloxone. This is our job. If we are caring for a woman with opioid use disorder during pregnancy, during a delivery admission, during postpartum, it is essential that we know that they have a Narcan naloxone prescription. Ideally, they should have one with them, and there should be one in their home that their family knows where it is located. It is very safe and easy to prescribe, and remember, it is a key risk reduction medicine that reduces overdose death. We want to share with all women who take opioids that we want them to stay safe, and that opioids can cause slowed breathing and accidental overdose, and that Narcan is a safety medicine as it reduces overdose. You can see here how to prescribe Narcan or naloxone. That's also available on the Save a Life resource that's in the MNO folder. It is so important that the nursing team utilizes the MNO folder, takes out both of the Narcan resources, the Save a Life, which is for the OB provider to explain how to counsel and write the prescription, and then the Quick Start Guide, which goes to the patient so that they know how to use Narcan at home. And remember, Narcan comes in 2 packs. We want to try to give one to the family if appropriate. Hospitals have been able to utilize the med-to-bed program so that patients can get the Narcan or naloxone prescription before they leave the hospital, do a much better job of making sure that that patient has the Narcan when they go home. I'm just going to show some of the posters that you may have seen at your hospital or posted around Illinois to really draw attention to the OB clinical team and why it's so essential that we provide this care to reduce the risk of maternal death. We must understand the messaging that overdose is a leading cause of maternal death, and that it's our OB clinical team's responsibility and job to make sure that we're providing optimal care for every mom with OUD. This includes starting MAT, providing naloxone, and linking to recovery treatment programs. And this has to be done for every patient. On the left is a flyer to really remind all of us to be screening with a validated screening tool. This can be shared with outpatient prenatal care sites to remind them that validated screening tools are so essential for screening all patients for OUD, both during prenatal care and on arrival to labor and delivery. On the right is that Save a Life resource that we hope you'll share with OB providers to really encourage them that every patient with OUD or who takes opioids regularly needs to be counseled and provided a prescription for Narcan naloxone. This is the OB clinical team's job. This can't be left to anyone else to complete. Finally, I want to address such an important issue, making sure that our providers and nurses on our clinical team understand that stigma and bias worsens outcomes for women with OUD, and that we must address this issue if we're going to provide optimal care for our patients. Substance use disorder is among the most stigmatized health conditions in the US and around the world. It is clear that through standardizing care, through protocols and checklists, we better understand how to provide optimal care, but it also creates a space and openness to address stigma and bias. Stigma and bias is one of the most important elements that we must understand in order to provide optimal care. We must change our thinking in order to really figure out how to provide optimal care for our patients. The old way of thinking, which we often heard when we hear about why we're testing women for OUD, the old way of thinking was that we need to identify moms who are taking opioids in order to identify babies at risk, and that members of the healthcare team were then the best people to care for babies with NAS. That is old way of thinking. And it is so crucial that we understand why we're screening moms for OUD and trying to provide optimal care. Thinking about how to provide optimal care means that we understand that we need to screen and identify moms with OUD early in order to connect them to treatment. That OUD is a life-threatening chronic medical condition, and that life-saving treatment is available if we're able to screen women and identify them with this condition early. And if we treat them with respect and dignity, we're more likely to have women coming in for care and be willing to talk about this issue. We understand that when we identify them early, we're able to provide recovery resources and help put them on the road to recovery in order to help women be in the best position to care for their newborns. Changing our thinking requires taking an honest look at our own biases. And we really encourage everyone on your clinical team to think about how stigma impacts care for women with OUD, and think about how empathy, respect, and support can improve the care we provide. One way to do this is to do a language audit. and to think about the words that our clinical team use. We really want to identify when we're using words that worsen stigma and bias. So the old way of thinking, using words like addict, abuser, negative, dirty urine drink screen, those are all stigmatizing words that were used to really blame women for this condition. We want to think about this as a life-threatening medical condition. So we talk about moms with opioid use disorder, babies with NES, misuse, a normal urine drug screen, an abnormal urine drug screen. Helping to make sure that we understand that words matter helps all of us think about how stigma can impact the care that we provide. Stigmatization by healthcare providers is a key deterrent to prenatal care. And why does it matter? Criminalizing substance use disorder in pregnancy is both clinically ineffective and ethically inappropriate. Provider encouragement and support for social services and opioid maintenance therapy programs increases patient follow-up and linkage to care. It's that encouragement and support that patients talk about all the time when they say why and how did they get on the road to recovery. It's almost always a provider or a nurse who treated that patient with empathy and respect and encouraged them on that road to recovery that helped women succeed. Providing compassionate care, judgment-free support, and close follow-up leads to the best outcomes. I encourage you to check out a short eModule video available for providers and nurses on stigma training at www.ilpqc.org called Why Words Matter, to think more broadly about how to reduce stigma and bias in the care that you provide. I want to make sure that everyone is aware of these two hotline numbers here in Illinois in order to help it make it easier for the OB clinical team to care for pregnant women with OUD. The Illinois Helpline for Opioids is a 24 hours a day, 365 days a year hotline that we can call to help us find a local treatment option for our patients. So if you're not sure where to get a patient to MAT and to recovery treatment services, call this hotline. The Illinois Doc Assist Warm Line is a really important resource. It's a free addiction medicine consult service for OB providers and the clinical care team to assist caring for patients with OUD and questions around medication-assisted treatment. They're available Monday through Friday, 9 to 5. And if you call during off hours, they will call you back the next business day. And again, an important resource for all of us to better understand how best to care for these patients. I'd like to review the key points we covered today. Drug overdose is the #1 cause of maternal death in Illinois. Pregnancy is such an important window and opportunity to identify these moms and provide them the treatment that can save their lives. Linking to MAT and recovery treatment services saves lives. This has to be the responsibility of obstetric providers and the OB clinical team. We must be able to take care of these patients. There are key steps that OB clinical teams need to take prenatally and on L&D to care for women with opioid use disorder. Use systems such as MNO folders, labor and delivery huddles, and OUD order sets to provide optimal OUD care for pregnant and postpartum patients, every patient, every time. Provide and document universal substance use disorder and opiate use disorder screening with a validated screening tool. You must confirm that you are providing the screening for every pregnant patient as early in pregnancy as possible during prenatal care and on arrival for delivery admission. This screening is necessary for all patients. For women with OUD, we must counsel and assess readiness for treatment, link to MAT and recovery treatment programs with a warm handoff. We must initiate the OUD expert clinical algorithm. Remember, it starts by going in and talking to your patient. Complete the OUD clinical care checklist. This will help you know that you have provided optimal care for your patient to reduce risk of maternal death from OUD. Provide Narcan and naloxone counseling and a prescription for all women with OUD or who use opioids regularly. Remember that there's an example for counseling and a prescription example in the MNO folder. Educate every mom with OUD on OUD and NAS and engaging in newborns care. It's so important to empower moms to engage in newborns care and help them understand their newborns care and how they can participate. Confirm warm handoffs for linking to clear and close follow-up. Every patient with OUD needs that 2-week early postpartum visit, and they should be followed closely during prenatal care to make sure that they're linked to the services and treatment they need. Actively reduce stigma across your clinical team. Words matter. These moms need our empathy, our support, and our care. Remember, in order to reduce risk of maternal overdose and achieve our goal of reducing maternal mortality from opiate use disorder and improving pregnancy outcomes, we must identify every mom with OUD, so we should be screening prenatally every patient with a validated screening tool. If you are not doing this in your office, please consider the steps needed to get this done. Remember, for every patient identified with OUD, we must assess readiness for MAT and link them to recovery treatment services. Every patient needs risk reduction strategies to reduce risk of overdose, including counseling for Narcan and a prescription. These are the key steps needed to reduce risk of maternal overdose deaths from opioid use disorder and provide optimal care for every mom with OUD. Thank you so much for listening today. We hope that you join us in figuring out how to provide optimal care for every woman with OUD to reduce the risk of maternal death, improve pregnancy outcomes, and increase the number of women who can parent their baby. If you want more information regarding resources that I shared today, please visit us at www.ilpqc.org or email us at info@ilpqc.org. Thank you to our funders and sponsors that make ILPQC possible.